Hello, I'm Baya Enoch. Today I want to take you through a brief discussion about history taking. So what is history taking? History taking is a conversation that takes place between a patient and a doctor with the name of the doctor, getting to find out what problems the patient has so that they can be able to help them. Now, the fact that we said it's a conversation, then that means you need a few things. And one of the things that you need for you to be good at history taking is your communication skills. You need to be very good at communicating so that you be able to communicate with this patient or to have a good conversation with this patient and know exactly what is the problem. 2, you need your medical knowledge. The conversation you're having with this patient is aimed at knowing what health problems this patient has so that you can be able to help them. So you need to be a good communicator and you need your medical knowledge for you to be able to get a good history from a patient. Now, we said it's a conversation, or we call it a history taking process. So like all the other processes, history taking has some stages. The first stage, creation of a rapport. We want to create a very good environment for the patient to share whatever they have with the health provider or with you. So how do you create a good environment? 1, greet the patient, offer them a seat, introduce yourself, and tell the patient what your role there is. Then after that, go to the second stage, and the second stage is particulars. You want to establish the patient particulars, or you want a few details about this patient, and that is what you call patient particulars. So 1, ask the patient's name. 2, ask where they come from. Ask about their age. Ask about their marital status. Ask about their occupation, their religion. All this is essential for record keeping, for contact tracing, and for identification purposes also. After that, we go to the next stage, which you are calling the chief complaint. And in the chief complaint, we want to establish the reason behind the patient coming to the hospital. We want to know why exactly this patient decided to come to the hospital at that particular moment. So you can ask a question like, so why are you here today? Or what problems do you have today? And when the patient tells you what problems they have or what issues brought them to the facility, then you need to establish for how long they've had these problems. And only after establishing the duration the patient has had that problem, then we can say that the patient, you've gotten your chief complaint. So what I'm trying to say is that a chief complaint will not be complete if you don't know, or if it doesn't include the duration that the patient has had this problem. So a chief complaint will only be complete if it says the problem and the duration which the patient has had this problem. After establishing the chief complaint, we go to the next stage, which is history of presenting illness. And in the history of presenting illness, we want to know more about the problem that the patient presented with. An example, if a patient came in with a headache, then you want to know specifically where the pain is. You want to know when it started or how it started. You want to know, was it gradual on onset and as time goes by the pain keeps on increasing, or was it acute on onset? You also want to know the character of the pain. Is it throbbing? Is it pounding? Is it pricking in nature? You also want to know the timing. What times of the day do you experience this headache? Is it only in the morning hours or afternoon hours or evening hours, or is it throughout the day? Then you want to know if there are any things that when this person does or that this patient does that reduces the pain. Someone will tell you that I have a headache, or I've been experiencing a headache, but when I lie down, then the pain subsides. You also want to know if there are anything that worsens the pain. What does the patient do, or what are some of the things that when the patient does, then the pain worsens. Someone will tell you something like, if I'm exposed to a lot of noise, then the pain worsens. If I'm exposed to a lot of sunlight, then the pain worsens, and things like that. We also want to know about the associated factors. What other things happen when the patient is experiencing this headache? Someone might tell you that whenever I'm having this headache, then I feel like I'm going to faint in the next minute. I can't see properly, or my eyes become teary. Those are associated factors. So there's an acronym that we use when we are exploring pain, and the acronym is SOCRATES. S for sight, O onset, C character, R relieving factors, A associated factors, T timing, A aggregating factors, and S for severity. Is it so severe that the patient cannot do their daily activities, or is the patient sick but then they can still go about their daily chores or their daily activities? After that, we go to the review of system, and in the review of system, we now look at what other problems this patient has apart from what brought him or her to the facility, because a patient might be having another problem, but to them, because it's not nagging or because it's not giving them any discomfort at the moment, that's not a problem. So that's the essence of reviewing the other systems. And when you're talking of review of systems, we think of all the other systems or the other body systems that we know from our anatomy knowledge, and think of what can go wrong in those systems, then start asking questions on those systems so that we can establish whether this patient has other problems or not. An example, if you want to review the respiratory system, then you can ask about things like whether the patient has difficulty in breathing, whether the patient is coughing, whether the patient is sneezing, whether the patient has any chest pains and all that. In the GIT or the gastrointestinal system, you can ask about things like appetite, whether the patient is experiencing any episodes of loose stool, any episodes of vomiting, any abdominal pain and all that. So each system has some things that can go wrong. So in review of system, think about what can, pick a system, then think about what can go wrong in that system, and then ask questions about that. After the review of system, we go to the past medical and surgical history. We want to establish whether something that happened before to the patient might be contributing to what the patient has today, or might influence how we are going to manage this patient today. So in past medical and surgical history, we ask about things like any admissions, that is hospital admissions, any surgeries done, any blood transfusions done, or whether the patient has any known food or drug allergies. At the end, we might need to prescribe some medication for this patient, and we don't want to give this patient medication that is going to affect them, or medication that this patient is reacting with. So that's the essence of reviewing the past medical and surgical history. After that, we go to the personal and socioeconomic history. We want to know the hobbies of this patient. We want to know the lifestyle of this patient, because maybe lifestyle is the one that is contributing to whatever this patient is suffering from, or the lifestyle of the patient might have an impact on how we are going to manage this patient. An example, if someone is alcoholic and you want to prescribe some medication to them, then they might need to stop taking that alcohol for a period of time as they're taking this medication, so that the medication works well. After that, we go to the family history, and in the family history now we stop focusing on the patient and focus on the family that they come from. We want to know if there are any histories of chronic illnesses, and when we're talking of chronic illnesses, these are illnesses like diabetes, hypertension, asthma, tuberculosis, cancers. These are diseases that can be passed from, or can be inherited, and if they're inheritable, then our patient may be having one of them. If it happens that a member of the family has it, maybe he or she also got it and she's not aware. So that will help us in determining how we are going to manage this patient also. Then finally, if it's a lady patient, we go to the obstetric and gynecological history. And in the obstetric and gynecological history, we are going to focus mainly on the reproductive system, where we're going to ask this patient about the menarche. And when we say the menarche, we are talking about how old they were when they first got their periods, how the periods are, when they last got their periods, because we are trying to establish if this patient is pregnant. If the patient is pregnant, then you might be forced to give a different management depending on the age of the pregnancy also. And we also want to know if the patient has ever carried any pregnancy and what was the outcome of this pregnancy. Now, once you are able to get all this information from a patient, then you can be able to deduce or to make your diagnosis or find out what the patient really is suffering from and manage them appropriately. Whether you're going to prescribe medication for them, whether you're just going to give them some advice and allow them to go home, whether you're going to send for more investigations, or whether you're going to refer this patient. That will be the next step. But first, what will make you decide what you're going to do to this patient is you getting a good history. I hope you learned something. Let's meet next time. Thank you.